Hello. I hope you're all very well. Um, I understand that you were all master's students at the University of Derby. I was in your seats just 1 year ago. I did not have the privilege of learning about Klinefelter syndrome, so this is a really exciting opportunity. A brief introduction. My name is Daniel Lodge to be precise, Lodge. I have a bachelor's in forensic psychology with honours. I have a master's with distinction in forensic psychology, and I'm looking very soon to be starting my PhD um, in in um, in autism and stalking behaviours. I'm very excited to have the opportunity to be given to me by Dr. Rachel Wheatley, Georgia Harris, and Alison to have this opportunity, I guess, to discuss with you the literature, the academic side of things surrounding Klinefelter syndrome. So I'm going to break this down into two parts. And the first thing I'm going to do is I'm going to just give you a bit of an overview of my deep dive into Klinefelter syndrome because it became very apparent after discussions that my colleagues had with Alison and other wonderful people who felt like there was just something that needed to be known and needed to be understood here in the criminal justice system and just in society in general, I guess, is that there are individuals who are amongst us who have this condition called Klinefelter syndrome. Um, and they can often be misunderstood, which is often the case with often what I find when I look at autism in my autism studies or in many other areas of working in a prison environment. I found often that a lot of the men had difficulty with thinking skills and therefore would often be just misunderstood. They'd also misrepresent themselves in speech and language and thus not receive the support that they would thrive off if given. So when Klinefelter syndrome was introduced to me by Dr. Rachel Wheatley, I was really intrigued and interested. I have an obsession with things that I don't understand, and so I set about trying to understand it. And then I was given this really wonderful opportunity to write a rapid review assessment. This is a one stop short of a systematic review of all the literature um, concerning Klinefelter syndrome. And I've been working on that now for the past 4 weeks. And I would say I probably have between 2 to 4 weeks left of just combing through every day all of the literature, making sure I haven't missed anything to understand both Klinefelter syndrome, but also the impact that having Klinefelter syndrome can have on individuals who end up in the criminal justice system. That is what you are here to understand as you do your master's degrees. So please allow me an opportunity just to tell you a little bit about Klinefelter syndrome. So you're going to stare at my boring face for a little bit longer. And then I'm going to pull up some articles to look at Klinefelter syndrome in relation to crime. Before I do that, I want to say a very warm thank you to Georgia for asking me to um, do a very short video for you on this. I'm very grateful to have been invited, and I'm very humbled to be able to share these insights with you all. And I guess before I really get into this, if any of you have still yet to decide what you'd like to do for your studies, for your thesis, for your master's degree, and you take this very seriously, I hope that this insight can help you. And if you are intrigued, by all means, please let Georgia know, and she can pass on some contact details, or we can make contact. And I'm more than happy to give you some support and assist with your studies. So, Klinefelter syndrome was first reported many years ago in the 1940s after 9 men were found to have an extra X chromosome, which resulted in a genetic makeup of XXY. Um, this was supported by the increased excretion of follicle stimulating hormones. Now, this was in the 1940s, and since then, it is tentatively thought that around about, just generally, because it's very hard for us to really truly know, we have limited studies on this, but generally, it is thought that around about 150 out of every 100,000 live born males are thought to have Klinefelter syndrome. From here onwards, I'm going to refer to Klinefelter syndrome as KS. Okay. Now, this is when we consider that on a worldwide basis, 150 out of every 100,000 live born males. However, it is important to note that many studies previously have predominantly involved Japanese and white individuals. So it's very hard for us to know the numbers of African males or black males in the West and so forth. And other minority groups too, when we think on that. More recent localized studies have found a slowly rising prevalence universally. However, there are those significant demographic differences that affect prevalence. And so therefore, I would argue it is still generally really unclear as to how frequent KS is. What we do know at present concerning prevalence, measured on a prenatal and postnatal basis from the very few studies that are available, is that around 153 to every 100,000 males are thought to experience KS in Denmark, based on prenatal examination. In Australia, the reported figures are that 223 to every 100,000 males are thought to experience KS based on prenatal examination. In the United States, it is thought that around 166 males per 100,000 experience KS. However, amongst ethnic Asian males, the prevalence was 355 per 100,000. It's important to note that that is quite a significant jump, but the data that I got that from in the study, the numbers of ethnic Asian males that were sampled were they were very small, very, very small. So it's something that we need to be quite critical about and thinking of when we're looking at this literature and talking about it. Diagnosis of KS is rare, and little is known of the impact that this can have on male individuals living with KS, who are walking amongst us today but are undiagnosed. They have no idea or concept of what they are experiencing, and I will go on to talk about some of those experiences soon. I mean, this is especially in comparison to males who have been diagnosed from a young age or in early adulthood, which are the most common times when males are diagnosed with KS, early adolescence or adulthood. Diagnosis of KS generally relies on clinical appearance. And so that's problematic, because there can be no universal agreement on what those clinical signs should be to warrant further investigation of additional sex chromosomes. When a child is born, on presentation, it is very hard to determine that they have additional sex chromosomes. Only a fraction of cases, somewhere between 24% to 40%, are actually accurately diagnosed, and the bulk of those are in adulthood during fertility investigations. So couples who are in relationships, the male is trying to impregnate the female so they can have a child, and they are struggling to impregnate. So tests are done to determine whether the female is having biological difficulties, which mean that it's hard for her to fertilize, or if it's the male. And only in those investigations, generally, are adult males discovering that they have KS. there are there are signs that males can have KS, but these signs cannot be generalized. For instance, males with KS usually have small testicles, and around 10% of males diagnosed with KS also experience the medical condition known as azoospermia, which is defined as a blockage that prevents sperm from entering the ejaculate. Um, so again, very hard for this to be discovered, very hard for this to be assessed without a specialist reason to do so, and very hard to do in young adolescents as well. So there, I've touched on, difficulty with ejaculation, and the size of testicles, which are sometimes clinical markers for KS. The literature that discusses sexual function for males who are experiencing KS has been very limited, but in recent years it is growing. And there is evidence of intersectionality between males' experiences of sexual dysfunction and Klinefelter syndrome. Males who have been referred to outpatient clinics for sexual difficulties revealed an increased prevalence of KS. So a lot of the diagnosis of KS is actually happening in male sexual dysfunction clinics, or clinics for sexual difficulties. This is interesting because that's where a lot of our diagnosis. Remember, a lot of the males with KS are undiagnosed, so we're only really catching males with KS because they're trying to achieve social goals like positive sexual function, or having a family, with their partners, and they're struggling with that. So then they're going and asking why, and through those assessments discovering, oh, I have this whole condition, I've had it my whole life, and no one told me, and I didn't know. And that can be quite difficult, I imagine. So I would argue it is a more probably common experience that males experience sexual dysfunction throughout their livelihoods, compared with the background general population. However, evidence is really limited on these issues, and the studies to date do not present a clear and concise picture. For instance, self-reported experiences of erectile dysfunction for males with KS ranged between 2.5% upwards to 23% in the studies that I looked at. But this is not dissimilar to the experiences of control males who also experience sexual dysfunction or infertility. So I would argue that it's possible that sampling bias has played an important role in these findings, in that there may be similar risk factors and shared experiences for groups of males with KS and groups of males without KS who are experiencing erectile dysfunction and infertility difficulties. So you may be wondering why I'm talking so much about fertility, ejaculation, and these subjects, but the reason that I mention this so prominently in what I'm discussing here is because it is one of the key ways that males discover they have KS. And if you think about that experience as a male, you're struggling to achieve your social goals. You're really having a lot of difficulty creating a family with someone that you love and care about. And then you discover that you have this lifelong difficulty that literally defines your genetic makeup, and you have this additional chromosome. I imagine that could be quite overwhelming for some males, and it can change how they view their sexuality, how they view their ability to procreate. Despite this, sexual desire in the studies that I looked at so far in my literature review were reportedly decreased by between 10% and to 61% of males with KS. That's quite a wide range. So as you can see, that's very, you know, the studies that I looked at were very varied, and they've yet to be replicated. So we need to take this very cautiously. And that is the case with a lot of the literature around KS. It is not as well understood as I think we would like. And so many ideas for studies, if they're coming up, write them down. So I want to touch briefly on the role of sexual function with regards to the role of, and there's a reason for this, because we're going to talk later about sexual crimes. With regards to the role of orgasmic function for males experiencing KS, there was a recent study that reported there are significant decreases in orgasmic function. However, in 1997, another study found there was less significant decreases. So again, what we see there is two studies done separately, one in 2018 by Skakabak in Denmark and one by Yoshida in Japan in 1997, and they showed very varied ranges in their decreases in orgasmic function. So this cannot be generalized. However, both studies did report orgasmic function decreased. One reported very significantly more than the other. So despite the previously reported findings of sexual experiences of males experiencing KS, frequency of sexual intercourse does not appear to be affected. So males struggle to ejaculate, they have small testicles, they achieve orgasm at a significant decreased level in some studies and less significant in other studies. However, the frequency of the sexual intercourse does not appear to be affected. And interestingly, it seems that males with KS are as sexually active, if not sometimes more, regardless of their cohabitation status, so living with partner or in a relationship, as males without KS. And this has been found in multiple studies from the 1980s and in the early 2000s. That is very interesting, absolutely. So the desirability to have sexual intercourse is still there. It is still a driver, despite the biological difficulties. Now, Klinefelter syndrome can impact males beyond the sexual realm. Individuals or males with Klinefelter syndrome can be characterized by a range of cognitive deficits that I've witnessed throughout the literature in my literature review. Males with KS present lower full-scale IQ scores, generally scoring about 10 points lower than the general population. However, it's important to note this is not low enough to be considered an intellectual disability. So you've got a group of men who are scoring lower on IQ, but not so low as to be considered to have an intellectual disability. But they're still at a 10 points disadvantage to the general average in the population. So again, it's a little hole that the males with KS fall into, that is being missed and not identified, and therefore there's no support for males in that regard. The IQ deficit for males is mostly reflected in verbal IQ areas. Historically, receptive verbal deficits for males experiencing KS have been observed in auditory processing and semantic memory. So those of you who have done forensic psychology at a bachelor's level will be familiar with the roles of semantic memory and auditory processing in the brain. Auditory discrimination, processing and the decoding of words that are coming in and being expressed outwards. So when we think about that on a cognitive level, deficits to brain functioning with regards to communication you know, males with KS experience limitations to their abilities to comprehend linguistic stimuli. So this greatly impacts their ability to recognize language and perceive it. This can have an impact on their expressive skills, especially expressive language skills. Deficits towards this with males with KS have been observed in the onset of speech, the retrieval of words, expressive skills, speech and word articulation. So when we think about this, we think about the developmental and social nature of young males, how that can be impacted by these deficits. And dare I say, across the entire life course, not just in adolescence. So if we go beyond IQ, language, and executive functioning, we can then also look at some of the drivers towards decision making. Often in prison settings, in my experience, the men that I've worked with and cases that I have been involved with previously, one of the most common things that come up in risk assessments for programs is a person's ability to use thinking skills. And there are programs that exist in prison towards thinking skills. Well, executive functioning is a big part of this. The ability to organize, plan, consequential decision making and judgments. So thinking about what you are doing and the potential consequences of that. Well, males with KS experience a lot of deficits in this area. That deficits have been discovered in attention ability and inhibition, as well as the ability to exhibit cognitive flexibility. So the thinking is quite rigid, which is similar to a lot of the work that I've done with in autism studies, that sort of linear rigid thinking. And as an autistic person myself, have reflected on too. So despite these discoveries, it does need to be noted that very few studies actually exist on executive function in males with KS, including the working memory. So I present to you another study, should you desire to do it. Difficult to do at masters, but maybe if you're looking at postgrad work and you're interested in KS, very few studies on executive function in males with KS. So I guess the implications of KS on executive function does leave a lot of questions to be answered. However, the impact of KS just in general on the lives of male adolescents and adults is much clearer in the literature. There are a lot more studies in this area. Around 76% of 310 children and adults with KS reported that KS presented negative consequences to their quality of life. Many boys aged between 8 and 18 report significantly lower quality of life on physical, psychological, psychosocial, emotional scales. These findings have been found in other studies in Norway and Denmark. Sleep disturbance, poor sleep quality as a result of all of these difficulties with emotional, social, physical and psychosocial issues exists. And so therefore, when you're thinking about treatment, these men are having to get treatment these men and boys are having to get treatment for a wide variety of issues, from mental health to sleep quality. It's a lot. It's a lot to take on every day. How do you function, hold down jobs if you can't sleep? How do you function in society if you have social deficits and you really struggle? It's very hard. I imagine a lot of these males fall behind, or they get left behind by a society that always wants to move forward. That is speculation on my part. What I will say is that, you know, KS, this provides males quite clearly in the research with a poorer quality of life, lower income, lower employment, and a lesser chance of living with a life partner. And as we discussed previously, um, that involves um, procreation, creating a child together, a family. There's a lot of pressure that can be applied to these goals when you can't actually do that, and you don't know why, because you've not been diagnosed with KS. You know, think about it: infertility, psychological comorbidity, learning difficulties, difficulty maintaining social relationships, difficulty maintaining employment, a dissatisfaction with the healthcare because you don't know what's happening to you, and there is no general consensus in the healthcare of how to assess whether you have KS or not. You know, and then there are challenges there. So then you have testosterone treatments. Well, that provides a lot of challenges as well. Imagine that you've grown up with lower testosterone your entire life, and suddenly you are now experiencing testosterone. And we know how profound and important hormones and hormone treatments can be and have on males and females. So I will end this part of my lecture very soon by just saying males with KS appear in the literature through my review to face a significant number of negative experiences in the medical, neurocognitive, and psychosocial realms of their lifespan. And we don't really fully understand the impact of the interactions between genotype, phenotype. There is so much more to be understood about the day-to-day experiences of males who experience KS in cultural and societal contexts as well. So I'm going to take a brief pause here on the video, and I ask that the video be paused so you can have a discussion about everything I've just shared with you. And in the second section that I'm going to do, which is going to be shorter, and I'll explain why, we're going to look at Klinefelter syndrome and crime. Hello, welcome back. This second part will be brief. I'll explain why, but thank you to everyone for listening and being so patient whilst I did a lot of talking in the first part. I wanted to be able to give you just sort of a really good empirical overview of the challenges that males with KS experience. Alison works with the charity and will be more than aware of the social challenges and the difficulties that males with KS experience. And it is an area that myself, Georgia, and Rachel have started to now show real interest in after being passionately, you know, passionately communicated to about this area. And now I'm going to talk a little bit about criminality and its relation to KS. And I did a second literature review that I'm currently writing up for publication, and it is very difficult to talk about criminality and KS at the moment because there is so little to be found. I have a folder at the moment of 16, I repeat, 16 journal articles from around the world that I've researched in depth Klinefelter syndrome and criminality. So just very quickly, I searched. I've got one more database to search in my literature search that I'm doing. So my 16 are based on searches of around about 9 databases so far, and these databases are the most common, frequently, and most popular databases in the world. I have one more database to look into, and I'm expecting to find maybe a few more papers in there, but not too many. And so, what I've discovered so far in my search is that a lot of my um, work, a lot of my papers, apologies, a lot of my papers come from the 1970s, when there seemed to be a little bit of a, let's say, interest in Klinefelter syndrome, um, and criminality. Um, so it's great to have the foundations to work on, and this paper is a good example of that. I have quite a few papers from the 1970s that I will be writing about. As you can see here, Johannes Nielsen, um, you know, found that around 56% had a record of criminality. Um, but this study is quite old, and we don't have any real direct links in this study to why. And there are complications with this. It is very difficult. So what we could do is look at some of the more recent studies, but we have to reflect on the fact that this study did take place in Denmark, and a lot of the data that we work with has come from Denmark. So if we look at this study here, this is a very different kind of study that you could see here that looks at Klinefelter syndrome and fire setting behaviors. This is a brand new study that is just released, and it uses a case report but also a review of the literature. And it's important to understand that the literature review on KS and fire setting behavior followed a case study of a male, a young male, an adolescent male, who was diagnosed with KS and who presented with incendiary behavior despite having no psychiatric history. I would be skeptical to present this as solid evidence. What I would say is we need a wider picture to be presented of males who are diagnosed with Klinefelter syndrome and fire-setting behaviors. And this needs to be done in line with the evidence that we already have on males and fire-setting behaviors as well. So they did do a scoping review and found, more case reports. However, there was very little that was found, and I think this is because there is very little empirical literature that has been done with males who experience Klinefelter syndrome, and specifically males who are involved in offending behavior. But when I think about it, if males with Klinefelter syndrome are involved in offending behavior, and this is based on the literature that I've read, it would be because of part A of our lecture today, like the difficulties that they experience with, the development across multiple realms of their lives, and their ability, how that affects their ability to communicate and understand what people are saying to them, their ability to live lives that are, I guess you would say, common concepts of family and settling down and staying in employment. These issues are risk factors, I would argue, And when we look at risk factors and protective factors, we know that having a family, having steady and secure employment, um, and are protective factors away from offending behaviors. So I ask that you just think about that as we go through these papers. Now, this particular study focused on younger males. I would argue that maybe it's hard to find Klinefelter syndrome and fire-setting behaviors in older males with KS if they have been able to ascertain some of those protective factors that are available to them. However, in this, I would also ask that we reflect on, the literature that suggests that males with KS struggle to develop consequential thinking. So think about that when we apply it to fire-setting behaviors. We go back in to a sexual offending literature review that was done very recently, actually, and this was very interesting. To be honest, they identified 53 relevant papers to the study, but only 10 met their inclusion criteria. So it shows you how little research has been done, and how it would be helpful to practitioners like Georgia and Rachel and Alison if they have more evidence rather than just seeing patterns and going, I don't know, but that, you see, my experience tells me this, but it's very hard for us to support or make, or convince judges to make more informed decisions, or work with the CPS or work with different multi-agencies if we don't have the empirical literature to support it. And so this speaks for itself. This was a review, and only 10 papers met their inclusion criteria. All but one were prevalence studies conducted in a prison or hospital setting, so very unique. We have very few studies that have been conducted just, in the community post offense, or any discussions pre-offense, like preventative. We were thinking about prevention there, and again, mentioned earlier on, I mentioned, a lot of these studies are done in Denmark. This was very much the case here as well. The one study was a Danish register-based cohort study that did suggest an increased risk of sex offending amongst males with KS. Probably established before the diagnosis was made, and therefore any hormone replacement instituted. So it's important to recognize that one of the concerns that I have about studies is that one of the treatments for Klinefelter syndrome is testosterone therapy. Well, if you have done your psychology research, you'll know the impact of testosterone on male behavior and on behavior in general. Testosterone creates, agitation and aggression, along with several other hormones as well. So, the introduction of testosterone into a person's life for the first time could be a driver to these behaviors, but we just don't know. We just don't know in relation to KS. We don't know. And so that's a claim that I and no one else can make right now. What I'd also say is, we must also reflect earlier on my literature review. We found that males who had low libidos could, struggled to get erections, and struggled to achieve orgasm, and also excrete semen. Also, it didn't seem to affect their desirability to engage in sexual behaviors, and so there is something there that is driving a commitment to sexual behavior. And in a lot of the studies that I looked at, males tend to be a little more promiscuous. They tend to have multiple partners. because they're not settled into relationships, because they can't generally create children so easily and as such. So when we're looking at sexual offending and sexual behaviors in general, um, it is very hard to make generalizations um, about this, because there's just so little. As this paper shows, only one study really could could provide any support, and we cannot go around saying, right, well, there's an increased risk of sexual offending amongst males with Klinefelter. We just can't, because there's insufficient evidence to support this. But it is something that we can argue that is a research gap that requires a lot more investigation. And so I present to you another study potentially that you could potentially look into in your research careers or your studies. Here we have another review that it wanted to understand, see if there was a pattern of just general criminality across the scope. As you'll notice from the names, this again, another Scandinavian study. I will say Anne Skakabak done a lot of research in this area and has worked really hard to try and understand this, so a lot of credit absolutely there. And what I will say is that generally, I've also just noticed that I'm looking this way off the screen, but I'm actually looking at the work over there on the screen, so I apologize for that. Very confusing and odd. But back on subject. What I'll say here, this study just found generally that, and this is a more convincing study, might I add, found that men were more frequently convicted for sexual abuse, burglary, arson, and other reasons. So earlier on, I showed you the case study regarding fire setting, and we are, interested, and I guess into whether there are more sexual offences. This study would suggest there is. However, again, we must stress that we don't know if this is because of KS or because of testosterone treatments, the clinical care treatments that they're experiencing, or we also don't know if the time of diagnosis of KS interacts with whether these numbers could be higher or whether they could be lower, for instance. That's really tricky. And the increased crime rate could also be partly or fully mediated by poor socio-economic conditions, which we know, and as I said earlier on, we know that males with KS do experience. So my indicator would be that KS, at the moment in the literature, the pattern that I'm identifying is that KS comes with a whole tremendous amount of difficulties that are cognitive, social, psychosocial, and biological, of course, that then create the conditions for risk factors, which then may proceed into offending behaviors. I'll finish with this one here. This study I thought was particularly interesting. This is a case study, and often in my literature review I'm finding a lot of case studies because it's very hard to find males with KS who could do studies. Remember, many males are undiagnosed. Those that are diagnosed, it's very hard for them to find that they are needed for research. It's very hard to identify those males for research. And what was found in this study was a 44-year-old male with KS who had erectile dysfunction, so they couldn't get their penis erect, but somehow had an increased libido, so desire for sexual function. He used a drug called sildenafil to manage his erectile dysfunction so that he could have sexual experiences, but also manifested in having very high levels of hypersexuality, which they would exhibit through very frequent masturbation, very promiscuous sort of sexual experiences with many different partners who they would consider to be casual sexual partners. And they also, at a very young age, had a conviction for a sexual offence, and I think it was 17 years old, which is a very young age for a sexual conviction. Um, so this would be considered a very interesting anomaly in the research, because what we're seeing here is somebody who you would think would not have much sexual desire, but actually had a lot. And I point this case out because this supports the general literature that says that males who experience KS still have sexual desirability and engage with a lot of sexual desirability on the same levels, or if not more, as I said earlier on in part A, as males without KS. There is something going on there. There is something there within that I find very interesting, that I think also warrants investigation. And if anybody sat in this room watching this lecture that is um, would be interested to, to investigate that or talk about that, then please, by all means, let me know, or let your lecturers know. So what I will do is I will close by just saying thank you for listening. I really do appreciate it. I've done a very informal kind of talk on this today. I could have got loads of slides together and done lots with that, but I felt like it was best just to have a conversation and talk about it and present it as it is. The literature is very sparse. We need a lot of research on Klinefelter's syndrome in general, but also in especially in relation to criminality. And I think the work that Georgia is doing by bringing this to you, especially with Alison as well, is really, really important. And I'm pointing that way. They could be over here as well. I don't know where they're sat in the room, so I apologize. And I'm very grateful that I've been asked to speak on this today as well, and to present the literature that I feel like I've become an expert on this over the past month, because I've spent so much time in this literature, and over the next month I will continue. If you also would like to become an expert in this, please dive into this subject. We need researchers or people, the future of this discipline, to show an interest in this. And I think it's important because there are many ramifications of this which I find in line with ADHD and also in line with autism. There are no treatments for autism. For ADHD there is, and those treatments for ADHD modify people's ability to focus and function, and with autism they don't. With Klinefelter syndrome, I find it very interesting because there is this natural biological thing which is happening in males, which is dictating their cognitive, social, biopsychosocial abilities, and there is a sort of a treatment for it, but that actually also has an impact on their biopsychosocial, experiences. As a male with testosterone myself, I can account for, how difficult growing up that was. So, this is just so unbelievably fascinating, and something that I've become very passionate about, and I implore you to, if you are passionate about this, to please reach out, show your interest, and think of how you could develop a study for this, either at masters or beyond. Absolutely. This is a PhD. There are multiple PhDs of work available here. So if any of you are looking to go on to do a PhD and would be interested in this, by all means consider doing that. It would really help individuals like Georgia and Rachel, who have to go and convince and educate the criminal justice system about these matters, and my work will do that. And then there's great people like Alison, who are trying to inform the community, the public health, so many multi-agencies, and we need more. And the very people listening to this lecture who are sat in this room right now, you're some of the people who could do that, and so I really hope that you can. I will end this lecture now by saying thank you very, very much for listening. I've taken up quite a bit of your time, around about 40 or so minutes, I think. But thank you so much for listening. I hope you have a wonderful rest of your day. And if you want to get in touch, just come find me online. I am on X at Daniel A Lodge, Lodge. Or just speak to Georgia. I'm sure she'd be happy to pass on an email or a way of contacting me. Okay. Thank you very much. Take care. Bye bye.